Bismillahirrahmanirrahim. Today we are going to start with the gallbladder. Before I start with the gallbladder's pathology, very briefly the anatomy of the gallbladder should be revised. The gallbladder is a small structure which lies beneath the right lobe of the liver. Its main function is to store the bile. The bile which is being formed in the liver, it is stored in the gallbladder, and then when the sphincter of OD that is closed during that period it is stored in the gallbladder, otherwise it goes directly to the small gut. And this common bile duct, you can see here the structure, the right and the left hepatic ducts, I hope you remember, they join to form the common hepatic duct, while the cystic duct is the one which carries the bile to the common bile duct, and common bile duct in a combination with the pancreatic duct opens at the sphincter of Oddi. The gallbladder is unique in few things, that its lining is different from the gastrointestinal tract, though it is derived from that, but the gallbladder lacks the submucosa. Sorry, I've got a bit sore throat. This is why my voice may not be so clear. The main function is that it stores the bile which is a combination of different components. The bile salts are there, the cholesterol is there, the lecithin is there. The main function of the bile salts and the lecithin is to keep the cholesterol in a soluble form and to prevent it from forming the stones, etc. Any disbalance or imbalance between the constituents of the bile can lead to the formation of stones. Gallbladder under the effect, whenever you take up some food, there are certain hormones which are released. For example, the cholecystokinin which causes contraction of it, and the bile is then expressed or it is excreted into the common bile duct. The bile is normally concentrated about 5 to 10 times, and there is also excretion of the mucus about 20 milliliters per day, which is added to it. And also the function of the mucus is to prevent the wall of the gallbladder from the digestive action of the bile salts, and this is how the wall of the gallbladder is prevented. The lecithin is also injurious to the wall if it is converted to lysolecithin, so the mucus layer acts as a protective barrier for the wall of the gallbladder. The process of cholelithiasis, the formation of the gallstone, is one of the most common surgical problems worldwide. In fact, the second most commonly performed surgical operations are for the gallstones. These are, in fact, they may be defined as inorganic masses which are formed in the gallbladder and less commonly in the common bile duct or the hepatic. The factors which promote the gallstone formation, there are different factors. For example, the cholesterol stones, they are more related to geography. For example, the American Indians have highest incidence. In our country, the people living in the in and around the salt range, they are more often involved, though it is quite prevalent in other areas as well. Genetic factors, the increased frequency, it is evidenced by the increased frequency in the family members. Age, it is more common in the increasing age, and incidence possibly is because of the increased concentration of cholesterol in the bile, and it is more commoner in the females to the males. The drugs which promote the estrogen, possibly because of the cholestatic effect of the estrogen, you may recall from the cholestasis when we studied it. Obesity is one factor which can lead to the formation of gallbladder. Obesity is associated with increased synthesis and excretion of the cholesterol. This is how it may lead to formation of the. A diet which is rich in fat and low fiber contents can lead to increased incidence of gallstone formation. Other factors, the dehydration may be one of the factors which can promote fasting. Continuous prolonged fasting may be a factor in the formation of the gallstone. Now the different types of gallstones which may be there, they are pure gallstones which are very less, the pure cluster or pure pigment, and the mixed ones. These are the three types which are normally found. Another form which is sometimes mentioned is the combined form, in which there is a pure nucleus of either the cholesterol and then upon which the multiple layers of different salts, for example the calcium bilirubinate, calcium carbonate, and the cholesterol along with the mucin glycoprotein, they can gather upon it to form the stones. But the mixed stones are the most common. They account for about 80% of the stones, and they are composed of almost all the elements of the bile which are there. Origin and types of gallstones. The gallstones can form anywhere in the biliary tree. The most common point of origin is within the gallbladder. There are three types we have already discussed. The structure and mechanism for gallstone. This is a brief table you can see here. The cholesterol excretion is increased in elderly, female, pregnancy, obesity, and whenever there is a rapid loss of weight. The impaired gallbladder emptying, pregnancy may be one factor, gallbladder stasis, that could be because of the prolonged fasting. When it is there, you don't need the bile, so there would be stasis of the bile, and the stasis of the bile can lead to cholesterol nucleation and formation of the cholesterol stones or the other stones. Fasting, total parenteral nutrition, definitely it abates the need for the bile. Spinal cord injury leading to immobility of the gallbladder and decreased bile salt secretion, which is normally there in the pregnancy. So these are the different mechanisms which are involved in the cholesterol stone formation. The composition of the cholesterol stone, they are composed of cholesterol and mucin glycoprotein along with the bile pigment and calcium. Here you can see this diagram has been taken from your own book. Normally the cholesterol is kept in a soluble form with the help of the bile salts and lecithin. But when either of these, there is imbalance in that, for example the bile salt are less, lecithin is less, or there is a supersaturation with the cholesterol, it would lead to formation of multilamellar vesicles, the gallbladder hypermotility, and the cholesterol nucleation would be there, and these filaments are formed. Then they acquire the form of simple plates, and a progressive accretion of the mucus and gallbladder hypermotility, and the calcium salts are added to that in order to form the cholesterol stone. So this is the process. First of all, because of the stasis of the bile, because of the increased concentration of the bile, because of the hypermotility of the bile, the cholesterol nucleation would occur, and this will lead to progressively the stone formation, the cholesterol formation. The pigment stone, on the other hand, they are formed of different composition. They are of two forms, the black and brown. The black stones, they are normally formed in the gallbladder when there is no infection, while the brown, they are formed because as a result of the infection. The composition of the black stones is they are composed of polymerized calcium bilirubinate, mucin glycoprotein, calcium phosphate, calcium carbonate, and the cholesterol, etc. While the bile brown, they also remain constituent again remains the calcium bilirubinate crystals, mucin glycoprotein, cholesterol, and calcium palmitate or stearate. The risk factors: hemolysis. The hemolysis leads to excessive delivery of the bilirubin, plus age, the hepatic cirrhosis, earlier resection, and the brown, they are because of the infected bile and stasis. These are the major contribution to the black and brown stone formation, pigment stone formation in the biliary. Morphology of the gallstones, the cholesterol stones, pure stones are often solitary, whitish to yellowish in color, and they may be greater than 2 to 2.5 centimeter in diameter. Normally, there are multiple smooth. They may be multifaceted when they are more than one, because they are somewhat, you can say, friable. While the mixed stones, they are usually smaller, multiple in number, and occur in a variety of shapes and colors. Cut section of the pure gallstone reveals concentric layers of arranged cholesterol, which are arranged around the central nucleus. You can see the picture of a cholesterol stone. There are multiple cholesterol stones. The cholesterol and pigment stones, they are compared there. The pigment stones, they are black in color, while the cholesterol stones, they are yellowish in color. The clinical features of the gallstones, they may remain asymptomatic for a prolonged period of time. They may induce biliary colic, especially when they go and they impinge in either the cystic duct or at the outlet of the gallbladder, in the gallbladder neck, and they can lead to acute cholecystitis or chronic cholecystitis. The complications of the gallbladder, the gallstones can lead to acute and chronic cholecystitis. The empyema of the gallbladder, post-strain gallbladder. What is empyema? When the stone gets impacted, say in the cystic duct or the neck of the gallbladder, there may be ascending infection. The ascending infection can lead to the formation of pus in the bile, which is known as the empyema of the gallbladder. Post-strain gallbladder, this is in fact a complication of the chronic cholecystitis. When there is a prolonged stasis, the fibrosis is there, deposition of the calcium salts in the wall of the gallbladder leads or turns the gallbladder into an eggshell-like structure. The cholelithiasis simply means the presence of the stones in the you can say common bile duct or the common in the hepatic ducts. Pancreatitis, gallstone ileus, pancreatitis, as you know, that could arise because of the obstruction to the flow of the pancreatic juices. The gallstone ileus, if the gallstones, they happen to perforate the gallbladder and leak out when there is empyema or when there is increased inflammation, this could lead to an ileus fistula formation between gallbladder and duodenum may be there, or large intestine, and ultimately, because of the chronic cholecystitis, carcinoma of the gallbladder, ascending cholangitis and inflammation, or because of the infection when there is obstruction by the gallstones. Now we come to the cholecystitis. The cholecystitis can be divided into acute and chronic. The acute cholecystitis is again divided into acute calculus and acute acalculus. As the name implies, acute calculus is because of the underlying pathology is the presence of the gallstones, while the acute acalculus, this is without the presence of any sort of calculus. The causes of acalculus, the surgical trauma leading to the hypoperfusion of the gallbladder, the multiple injuries, burns, fierce sepsis, these all lead to you can say the stasis of the bile, and the stasis of the bile, whenever it is there, it can lead to the development of the cholecystitis. Recent childbirth, dehydration, and diabetes mellitus are the other contributing factors which may cause the acalculus. The mechanism of damage, this is normally both in the calculus and acalculus remains almost the same. For example, I would briefly review that in case of the acalculus, the major contributing factor is the ischemia. The decreased blood supply to the gallbladder leads to that, while in case of, and whenever there is a decreased blood supply, there will be disruption in the mucus layer. This leads to injury, and injury propagates the whole process, leading to inflammation of the wall of the gallbladder, and that is because of the conversion of the lecithin to lysolecithin. The first, the chemical irritation, the mucous phospholipases, they hydrolyze the luminal lecithin to the lysolecithin, and this causes disruption of the normal mucosal glycoprotein, and the detergent action of the ball salts which are there, they would further enhance the process. Dysmotility of the gallbladder is there, progressively distension, and whenever there is distension, it will lead to ischemia, and later the bacterial infection may be there, So this is the whole process which may be there in both the calculus and the acalculus. Morphology of the acute cholecystitis. Grossly, the gallbladder is tense and large. Color may be violaceous, because of the inflammation, because of the congestion. This is so greenish black or reddish due to subserological hemorrhage. Outer layer is covered by a fibrinous exudate. Histological features, they include edema, leukocyte infiltrate in the wall, vascular congestion, suppuration, and finally the most dreaded complication sometimes is the gangrene because of the ascending infection. Here you can see a photograph of the acute cholecystitis. You can see the gallbladder is distended, which normally appears somewhat grayish green in color, is turned into totally red colored structure. Now the chronic cholecystitis. This is one of the most important topic from the point of examination. This is the chronic inflammation of the wall of the gallbladder, which may start de novo. It means that it may start at stone or may follow repeated bouts of mild to severe chronic cholecystitis. And 90% of the cases they are associated with cholelithiasis, means the gallstones are there and they lead to progressive inflammation because of the irritation of the wall of the gallbladder, and that leads to the chronic cholecystitis. And superimposed upon that are the repeated bouts of the mild infection. Normally, about one-third of the patients having this chronic cholecystitis, they may be positive for the E. coli. Morphology of the chronic cholecystitis. Grossly, you can see here this greenish, thick-walled and lumen is filled with the stones. Normally, this is the case in case of chronic cholecystitis. But remember one thing, that the wall of the gallbladder that may appear shriveled, that may appear grayish, that may be smooth, but the total thickness of the wall normally rarely exceeds 3 times its normal thickness in case of simple chronic cholecystitis. This is to differentiate it from the form of a gallbladder carcinoma, which is infiltrative, which also leads to the thickening of the gallbladder. And this thickening of the gallbladder is because of the desmoplasia, that is the deposition of the fibrous tissue in the wall of the histological appearance. This is very important from the point of OSCE as well. There is a formation of the erective mucosal folds, the hyperplasia infiltrated by mononuclear cells, desmoplasia, the formation of Rokitansky-S of sinuses. The Rokitansky-S of sinuses are nothing but dipping down of these you can say the lining of the gallbladder that dip down to form small sinus-like structures, which are there. I can show you here in this diagram. This is a Rokitansky-S of sinus, that is the glands dipping down into the wall of the gallbladder. The inflammation is here in the form of small mononuclear cells, that is the lymphocytes. The clinical features: recurrent bouts of colicky pain in the right hypochondrium or the epigastrium. This pain normally radiates to the right back below the tip of the scapula, nausea, vomiting, and intolerant for fatty food. These are the normally bloating or other features which may be there in case of the chronic cholecystitis. Now, what are the complications of the chronic cholecystitis? I told you one, post-strain gallbladder, that is because of the progressive accumulation of the calcium salts in the wall of the gallbladder that may be converted to a egg-like structure. Xanthogranulomatous cholecystitis, that is because of the presence of the cholesterol that can lead to a form of cholecystitis which is known as the xanthogranulomatous, because whenever there is a accumulation of cholesterol there will be formation of granulomas, and this is a xanthogranulomatous cholecystitis. Hydrops of the gallbladder. This is a condition which arises when there is excessive the dissolution of the bile is dissoluted, it gets thinned out, it gets accumulated, there is obstruction at the neck of the gallbladder and the gallbladder progressively swells up, and if there is no infection then it would be an enlarged, you can say like a balloon filled with the thinned out bile. While if the infection occurs there, the condition may be converted into empyema of the gallbladder, and progressively, if it is not relieved, the stones are there, the gallbladder is there, and it remains like continuous bouts of chronic inflammation. They lead to the development of carcinoma of the gallbladder. Now, a little bit about the choledocholitis and ascending cholangitis. Choledocholitis simply means the presence of the gallstones in the common bile duct. The symptoms are usually obstruction, pancreatitis, hepatic abscess formation, secondary biliary cirrhosis, and acute calculus cholecystitis. The ascending cholangitis simply means the ascending inflammation which goes up into the bile ducts coming from the liver and in the liver involving the small bile duct tube.